Hi everybody, welcome to another edition of Eye Care Today. I'm your host, Dr. Thomas Kislan, and today I'm joined with Phil Benyo from It's Your Health. So thanks for joining me today, Phil.
Yeah, we're having a lot of fun.
Remember, any of the shows you watch, if there's ever any questions, feel free to give us a call. Our office number in Hazleton, 570-453-2020, and in Stroudsburg, 570-421-3342. In Stroudsburg, we're on 9th Street. And of course, here in Hazleton, we're on the Airport Beltway, and catch us on the web, www.drkislan.com, and on Facebook and Twitter. So, what we're going to do again today, folks, is talk about some conditions that not only affect the eyes, but the whole body, why it's important to know about these conditions, and kind of how we as primary providers talk back and forth about how to manage these conditions. So, Phil, high blood pressure. A lot of patients that I see come through and they're on high blood pressure medication for many reasons. But when we talk about just hypertension, tell the folks out there what it is.
Well, high blood pressure is just simply that. It's high blood pressure. It's probably one of the most important things we do. It is the most popular diagnosis we see in the office. It increases incidence with age. We see men have it a little bit more than women. The way we check for it is we check your blood pressure. We now check blood pressure in 5-year-olds when they're at the pediatrician's office. We're now starting to check blood pressure in that early of an age to try to find it early, because there actually are kids who are teenagers who are on blood pressure medication.
What's a normal blood pressure reading?
Well, that changes. It depends if you have high blood pressure. Normally, we like to see your blood pressure at 120 over 80, okay? And so that systolic is 120, the diastolic is 80, top and bottom number. You know, if you don't have a history of high blood pressure, we allow it to get a little bit higher into the 130s over 80s. We used to call this pre-hypertension. We don't use those words anymore. Once your blood pressure kind of goes over 140 over 90, you're now labeled as having high blood pressure. Now, once you're labeled as having high blood pressure, the new goal is to get that pressure under 120 over 80. It used to be, you know, get it less than 130 over 80, 130 over 85, less than 140 over 90, but now they've found that once we have a diagnosis of high blood pressure, for the general population, the lower the better. I tell people, as long as you're not passing out, there's no such thing as too low.
And why does it matter? If you have high blood pressure, what happens?
Well, in the short term, there are some things that can happen. If your pressure is extremely high, you know, you can actually run into some ocular manifestations. You can have an aneurysm. You can blow out, you know, an artery in your brain, and you know, that's not good. But in the short term, there isn't much that happens. It's the long term. You know, your heart is a muscle. To maintain higher pressures, your heart has to work harder. Any muscle that has to work harder, what will it do? It gets bigger. The heart isn't designed to get bigger. As the heart gets thicker and bigger, it loses its key function, and that's its elasticity. It can no longer stretch out to accept blood in, so it squeezes. As it gets thicker, like a big bodybuilder, they can't stretch their arms out. Well, neither can your heart. And so that leads to heart failure. That can lead to heart attacks and all kinds of other problems related to that.
And what are some conditions that can lead to high blood pressure as far as, I mean, obviously being overweight, smoking? I mean, talk about some of those risk factors.
Well, the number one risk factor is something you have no control over, and it's who your parents were. You know, the number one risk factor is family history. There are some things you can do to raise your high blood pressure, you know, when you have that family history. So poor diet, high salt intake, high caffeine intake, being overweight certainly is a contributing factor. I don't necessarily think of those as pure causes. I think of those as exacerbations of family history. You know, we have people that weigh 400 pounds that have normal blood pressure and have normal blood sugar. It's just their family history. We have people that are perfect weight, they're marathon runners, and they have to be on 2 or 3 different blood pressure medications because it's in their genes.
And are there different guidelines as our age changes? So the older we are, there are different guidelines for blood pressure.
It's neat you ask that, because it used to be no. You know, it used to be everybody had it, whether you're 18 or you're 85, we had the same guidelines. And now the new Joint Commission for High Blood Pressure, or JNC 8 guidelines, now actually allow us in older individuals to let that pressure rise a little bit. And it's not so much because, you know, we're trying to watch the heart, but we're trying to look at all-cause mortality. And so when you're 85, high blood pressure is not going to kill you. It's the fall that's going to kill you. And if I jack your pressure way too low, and you stand up and get dizzy and fall down, that's not good. And so we're actually allowed to keep pressure a little bit higher in these older individuals. So like a 140s over 80s is actually okay. Whereas if you're 55, no, I got to have that lower.
Okay. And, you know, when a patient comes in and they have high blood pressure and, you know, again, we communicate back and forth about, you know, their diabetes, their high blood pressure, their cholesterol, you know, the eyes are interesting because years ago, we didn't know as much about high blood pressure in the eyes, but now we know that just like with diabetes, it can affect the blood vessels in the eye. And in the eye, again, when we take some of these pictures, these cool pictures that we take, we can actually see arteries and veins in the eye run next to each other, and they kind of crisscross. Well, if there's a blood pressure problem, those arteries and veins can actually compress each other, and you actually have bleeding in the retina, just like you do with diabetes. A little bit different areas of the eye, but patients can lose vision. So again, the eye exams are very important for these patients. If we see changes in the eye from the high blood pressure, again, a letter or phone call back to you is really, really necessary to help stay on top of these patients.
Absolutely. I think that's a great, a great point. I've had actually patients that you've seen who blood pressure is a symptomless disease. You don't have a turkey timer that says your high blood pressure, your pressure's up. You can walk into this office here and your pressure is going to be 200 over 100 and you're going to feel fine. You're going to check their eyes and see, wow, we have some problems here. You'll do a quick blood pressure check and see their pressure's through the roof, and then I get the phone call. And so, but that patient won't present to me for that. They're going to present to you. And so it's really important, to follow that proper eye care.
And it's funny because a lot of patients now they're amazed that we routinely take blood pressures now too, and we're starting again on the younger patients. We're being mandated also to take these blood pressures. So I think when patients not only go to see you, they come here, they go to their podiatrist, they're getting their blood pressure checked. So it's an important piece of their health history.
Yeah, that's really the first vital sign we take. Weight isn't even as important. Check that blood pressure.
Check that blood pressure. And then, of course, does cholesterol tie into hypertension?
It's important because there's a lot of coexisting diseases. High blood pressure and high cholesterol are just two of the many risk factors for stroke and heart attack. And so, when there's one, where there's smoke, there's fire. So it's important once we identify someone who has high blood pressure, maybe they smoke, maybe they're a guy, well, now they have three risk factors for coronary artery disease. If their cholesterol is up, we really need to get their cholesterol down, whereas someone who doesn't have all those risk factors, maybe we can let their cholesterol slide a little bit.
Yeah, I'm really cautious when I see the hypertensive patients who also have high cholesterol. We really look again at their retina and the small vessels, and if there's starting to be some atherosclerotic changes in the vessels, I worry about that because you not only can get, just like you said, a stroke, you can get a stroke in the eye.
Absolutely.
And a patient can throw a little plaque from their carotid or even from one of the valves in their heart. It can go up and block their one of the vessels in the retina, and they can actually lose vision in the eye. So keeping everything systemically down is going to really help with the eyes also. So high blood pressure is a very important condition. We're going to take a quick break, folks, and when we come back, we're going to talk about some more conditions that not only affect the eyes but affect the whole body. So again, remember, if there's any questions, feel free to give our office a call. You're watching Eye Care Today, and we'll be right back. Welcome back, everybody. You're watching Eye Care Today. I'm your host, Dr. Thomas Kislan. Today I'm joined by Phil Benyo, the co-host of It's Your Health, one of the great shows seen here on your local Channel 13 that gives all the great information about healthcare. Isn't that your tag?
Well, yeah, it's the fastest half hour.
The fastest half hour in television.
So this is like the second fastest half hour, but it is pretty fast, I have to say. It's moving quick.
So thanks for joining us. Some great information today, and if there's ever any questions, I mean, we're covering a lot of information in these two shows, folks. Please feel free to give our office a call, 453-2020 in Hazleton, 421-3342 over in the Poconos, and catch us on the web at www.drkislan.com. So we've covered diabetes, we've covered high blood pressure. I'd like to cover a set of conditions that we see a lot of, I think more recently now than probably in the last 10 years, something we call autoimmune disease. And there's a couple conditions we're going to talk about, but maybe explain to everyone watching out there, what is an autoimmune disease? What does that mean?
Well, autoimmune diseases are diseases where your immune system that fights off bacteria and viruses decides to not only choose bacteria and viruses as an enemy, but also choose part of you as an enemy. And so your immune system actually starts attacking certain joint spaces, okay? Certain glands in your body, blood vessels. And by attacking these, it's causing inflammation, which leads to a whole cascade of things that are not good. You know, that inflammation leads to scar tissue, which leads to destruction of the joint. You know, our body's really good at fighting stuff, and so it's not really good when it decides to fight ourselves.
And I think that's a word, what you said, inflammation is almost a buzzword now. A lot of these conditions we're talking about are inflammatory based. So diabetes has an inflammatory component. Hypertension, high cholesterol has some inflammatory components that go on in the walls of the blood vessels. And now we're talking about more inflammation here. So a lot of some of the treatments we're going to talk about are anti-inflammatory. We're going to talk about some natural treatments also. But one of the ones that I see a lot of in the office that have some eye effects with them is rheumatoid arthritis. So talk to me about what rheumatoid arthritis really is.
Rheumatoid arthritis is a condition where your immune system has decided to attack the synovium, or the lining of a joint. And so the most common areas it attacks are the hands. And it does a really good job if left unchecked. It will start attacking those hands. Initially you'll have inflammation. You'll sometimes see some redness over the knuckles and over the digits. We can see redness and swelling in the knees. We can see fever, fatigue, chills. This can sometimes go on for months before we actually figure out what it is.
And how's it different from just regular arthritis?
Well, regular arthritis is a wear and tear event. As we age,
we get older.
As we get older, right? Yes. Arthritis, wear and tear, or osteoarthritis increases with incidence in age, whereas rheumatoid arthritis, we tend to see that during very specific periods in our life. Usually we can see that in early, as your 30s, but up to your 60s. After 60, you don't see rheumatoid arthritis often as a new diagnosis.
And we can see it in kids.
Absolutely. Juvenile rheumatoid arthritis is it's a whole different fish.
Just saw 2 patients this past week, juvenile rheumatoid arthritis, and there's some eye effects you can have with that, something called iritis or uveitis. And so we look with the slit lamp, and again, this is a communication back and forth between you and their rheumatologist, make sure there's no signs of what we call white blood cells in the eye. And it's interesting, these patients, if they have a flare-up in their knees, let's say, these little kids, a lot of times it flares up in the eye, and mom will call and say, we were just in for an injection in the knees, and now Sally's eyes are hurting. Yeah. So JRA can be a real serious problem. But back to just regular rheumatoid, how are some of the, you mentioned about some of the ways you diagnose it. What are some of the treatments out there?
Once we have a diagnosis established, and again, sometimes it can take months to someone can come in with very obvious rheumatoid arthritis, but we can't prove it. And we can say, that's what you look like you have, but the blood test can be inconclusive sometimes for months. So it does take a little time to get diagnosed. The treatment is really about stopping that inflammation and getting that immune system to calm down. And so there's ways to treat the pain and the inflammation. We try to use, anti-inflammatories. We use but the mainstay of treatment, because anti-inflammatories and steroids have been around forever, but those people, their disease still progresses. To treat the pain, it's important for using things like fish oils. That helps reduce the inflammation. The mainstay of treatment right now are what are called the biologics, or disease-modifying anti-rheumatic agents. And these are things like methotrexate, Enbrel, Remicade. Some of these are pills, some of these are infusions that actually tell your immune system, just stop. You're not allowed to do this anymore. They work really well, but they have risks. Some of these medications can actually have eye effects that we have to have you keep an eye on. Some of these medications, when we tell your immune system to really cool it off, sometimes it cools it off for a lot of other things too, and it doesn't do a great job fighting infections.
One of the common medications is Plaquenil, that's used for rheumatoid. So a lot of times we'll see the patients, you guys will put them on Plaquenil and then send them to us, because Plaquenil can affect the retina. It's not very common, but it does happen. You get something called Plaquenil retinopathy, where the Plaquenil actually builds up in the retina, and when we look at it, it actually looks like a bullseye. It actually has some pigmented circles right in the macula, and the patient's vision can be reduced. So we watch for that. We do, again, retinal testing with our OptiMap. We'll do visual field testing, OCT scanning. So there's a lot of things that we check for and make sure they're not having any problems with the Plaquenil. It's very rare, but it's a great drug for rheumatoid. Another condition is lupus. Let's talk briefly about lupus and what that is.
Lupus is a much more broad autoimmune or inflammatory condition. They called it the great imitator years ago because it looked like so many different diseases. Lupus is, again, something that causes an autoimmune reaction. It often affects the skin, more dangerously, it can affect the vessels. Okay, people who have lupus that's unchecked are at much greater risk for cardiovascular disease because they build up plaque 10 times faster than the normal individual. They also have cerebral issues. You know, lupus can affect your brain. Lupus can affect just about every part of your body, including the eyes.
Yeah, I mean, Sjogren's disease is one of the main issues we'll see. You know, dry eye disease is one of the big things we'll see with Sjogren's patients. So this is a real problem with these patients. What are some of the medications that are used for lupus?
Lupus, again, it's about the anti-inflammatories and some of the disease-modifying medications that tell your immune system to cut it down. For lupus, we do use steroids more. You know, we don't have quite the treatment algorithms that we do for, say, rheumatoid arthritis or psoriatic arthritis, which is a whole different topic. Lupus is, again, about identifying it early because we see it a lot earlier. You know, rheumatoid arthritis we see in your 30s to 60s. You know, Sjogren's syndrome, that's your 40s, 50s, 70s, okay? Lupus starts when you're 15.
And it's all inflammation again, right?
Absolutely.
And where do omega-3s fit in? I mean, we didn't get to talk much about it today, but you know, we use omega-3s, the PRN omegas. You know, I think it's one of the best ones out there for treating inflammation in the eyes. So dry eye disease in these Sjogren's patients, you know, a good dose of this and the patients do really well. Where do you see that fitting in?
Well, I think you touched on it really well in the beginning of the show, is inflammation is bad. And because inflammation causes you to have an immune reaction, which leads to scarring, plaque formation, bad things, you know, and that's really the whole goal in life, is to avoid inflammation. And the omegas is something you can start very early in life to help keep that inflammation down because it has a lot of different anti-inflammatory properties. It's able to keep the vessels, you know, from getting inflamed, the joints from getting inflamed, because inflammation leads to destruction. We don't want our immune system, even for people who don't have rheumatoid arthritis, if we have any inflammation in our body, we're going to have an immune reaction to that inflammation that will lead to scarring, plaque formation, and just joint destruction. And so it's the key is to avoid it.
Bad stuff.
It's bad stuff, you know.
I tell patients the omega-3s, they're good for your eyes, your skin, your joints, your heart, your cholesterol. I mean, there's really no bad thing.
There really isn't any negative, and with these, they're great because you don't have the side effects that you get from the Walmart, you know, fish oils. You know,
burp it up all the time.
Yeah,
you can't take them.
Or loose stools. Whereas these, you know, they don't do that because they're the right oils.
Yeah, loose stools is a bad thing.
That's not a good thing.
That's not good.
We don't like that.
All right, we're going to take a quick break here. Again, you're watching Eye Care Today, and we'll be right back. Welcome back, everybody. Again, you're watching Eye Care Today. I'm your host, Dr. Thomas Kislan, and we're coming to you today from our Hazleton location. That's on the Beltway in Hazleton. Our address is 281 Airport Beltway. Phone number is 570-453-2020. And if you're watching us over in the Poconos in the Stroudsburg area, phone number there is 570-421-3342, and we're on 9th Street in Stroudsburg there. And again, catch us on the web, www.drkislan.com. And again, many thanks to Phil Benyo for coming out today and joining me on the show and sharing his insights on all this good stuff we have to offer patients.
These are fun topics, you know, get to talk about these.
Yeah, I mean, we've covered diabetes, we've covered high blood pressure, rheumatoid arthritis, we talked about lupus. Now let's talk about something that I think we both see a lot of because it can relate to some of these other conditions, but Sjogren's syndrome.
Sjogren's syndrome is one of probably the second most common autoimmune disease.
It's also the most common misspelled.
Yes, right? Yes, absolutely. Not there, though. It's spelled right. Absolutely. But Sjogren's syndrome is a condition where, again, our immune system has decided to attack a very different part of our body than these other disease states. Instead of attacking our joints or our blood vessels, it specifically attacks our secretory glands, okay? Mainly our lacrimal glands and our salivary glands. So we start to have inflammation in these glands, and inflammation leads to destruction, and we start not producing saliva properly or start producing tears properly.
And it's a little bit higher incidence in women.
Absolutely.
Right? And you know what we see in the eyes is, well, let's back up a little bit. How do you diagnose it?
Well, it's a very difficult diagnosis to make, you know, without getting pretty invasive. You know, we can sometimes do antibody tests. The problem is antibody tests can wax and wane. They will be positive sometimes when you're flaring, But if you're not in a real flare, the antibody tests will be misleading. You know, often we have to send people off to a specialist to consider a biopsy, which is usually a very good way, but you know, having your salivary gland biopsied is not the most fun thing to have done. Usually it's based on, you know, the history and the physical exam, you know, because there's some pretty decent findings.
Because if you're symptomatic, you're going to treat the patient anyway,
Absolutely.
no matter what that blood test says. I mean, sometimes I'll tell a patient who's frustrated, I'll say, you know, it's not important putting a name to it as it is we treat how you're feeling.
Right, because we would do the same either way, whether they have the disease state or not. And I would venture to say that they do have the disease state, and we just don't have the ability to test for it as well. And that happens, a lot of these autoimmune conditions are like that. That's why it sometimes takes, you just don't walk in and like we check your blood pressure and boop, you have high blood pressure. We diagnose that in 30 seconds.
Right.
These disease states take months to diagnose because they're just, they're tricky. They're hard to find.
And you know, you'll see some of these patients and send them off to us for some of the eye testing, because dry eye disease is one of the most common things we'll see with Sjogren's patients. And this is where I think in the eye arena we've made some real strides in helping some of these patients. Even some of the diagnosis of these patients. One of the things we do, it's called a Schirmer test, and it sounds barbaric, but it's really not too bad. We actually use an eye drop that numbs the eye, and then we have these little tiny strips that just sit on the corner of the eye, and it gives us a measurement over 5 minutes as to the amount of tears that the patient is producing. And if those tears are reduced, we know the patient has dry eye disease. So we can kind of take it from there and then start to treat these patients. The treatments are much better than they were years ago. We do, just like maybe oral steroids are used for some of these inflammatory conditions, we'll use topical steroids, eye drop steroids. There's a medicine out there called Restasis. It's an eye drop that actually is used to help increase the amount of tears that a patient produces. We'll sometimes use something called punctal plugs, where we actually put little tiny plugs in the tear ducts. I tell patients, think of your kitchen sink. Water comes out the spigot, goes in the sink, out the pipes. If you want to keep more water in your sink, you put a stopper in. Same thing in the eyes. We'll put a little stopper in the tear duct. It prevents the tears from draining as quickly. So we have that option. And then there's one of the things I like to say I kind of keep in my back pocket for these patients who are really bad is something called Evoxac or Salogen. Do you use that a lot of times?
Absolutely. And for me, I never think of the eye aspect of it. That's what I have you for. I think of it from the other systemic aspects is, the dry mouth, you need saliva. That actually has a protective effect in your mouth, and it helps protect your teeth.
A lot of these patients have gum disease.
Absolutely, big problem, because that dry mouth and lack of saliva can lead to real big-time bacterial problems that will lead to cavities. Also, it's the lack of digestion. The saliva actually does more than just make your mouth wet. It helps digest starches immediately, and it acts as a lubricant for your esophagus. So not having proper saliva leads to all kinds of eating disorders, it leads to weight loss, and then it can have other GI issues. I'll use a medication like that really for the saliva issues, because it can help produce and stimulate saliva production. It's not perfect, but it does work, and it doesn't really have any side effects. It's kind of a win-win. The worst thing it'll do is not work as well, but it does usually, especially earlier in disease state, it can help produce saliva, and the bonus is it starts to produce tears.
Yeah, if we do it for the tear production, we'll see patients get a little bit of that tear production. They'll actually notice in the mouth some more saliva. I found that in women, they sometimes get the side effect of the perspiration a little bit. They seem to, that bothers them a little bit more, because it can increase, salivation, lacrimation, perspiration sometimes. So those tend to perspire a little bit more. But for those Sjogren's patients, like we were talking about the last segment, omega-3s also can be very beneficial.
And again, you focus on the eye aspect. You know a lot more about the omega eye, products out there, because that's really where, things have changed as well. It's because they're now really manufacturing these things specifically for these conditions.
Right, but it all comes back, I think, to the inflammation. We've talked about inflammation in all these conditions over the these last two shows. Controlling that inflammation, whether it be omega-3s, steroids with your diet, very, very important. Any final words to tie things up? I think we covered a lot of information.
I think we did. I think this is really nice. I think what you're seeing here is how different specialties are communicating, and I think as we move forward, in medicine, we're going to find that this is what needs to happen. You know, we need to make sure that guys like me are talking to guys like Tom, and you know that we're all, and he's talking to the rheumatologist or the cardiologist or the neurologist or whoever it is, that we all have this real open level communication, because you know we're all about preventing disease and maintaining a healthy body, and so having everybody on the same board, I think, is important.
That continuity of care becomes extremely important, and it's getting easier with electronic records now. I mean, it's not perfect yet because my system's not tied into your system, it's not tied into Geisinger's yet, but I think we're getting there where, I mean, right now I can pull up a patient medication list or put in their pharmacy and I get their whole medication list, so I know exactly what the patients are taking. I think it's getting to the point where I can pull up their blood work right away. You'll be able to pull up exactly when their last eye exam was. So that continuity of care is very important. So I think my advice to folks out there is, no matter what doctor you go to, always take your list of medications with you. You know, maybe a brief medical history, so it kind of takes a little less time in the room for us to go over all that, and it just makes us communicating with each other and patients a lot easier.
You know, my father says always brown bag it, and I think that's a great technique when people bring in every bottle that they're consuming a pill or a liquid from, to bring it in and look at it, because you'd be surprised how many supplements they're taking that actually can counteract a lot of what we're doing, and how a lot of things that can be dangerous, or they're taking something that they weren't even prescribed. You know, it's really amazing what sometimes we'll just kind of willingly put in our bodies without knowing it, and so it's important to look at that whole thing.
Yeah, not just prescription medicine, but over-the-counters, very, very important. So I think that was the fastest half hour on television.
We'll see. I'm going to get the clock.
Folks, thanks for joining us. You know, again, if there's any questions, please feel free to give us a call. You've been watching Eye Care Today, and we'll see you next time.